to you about population health today, but the early session on the last day, we've already gotten the bios introduced. But I'm Michael, this is Ryan. Before we get too far into the presentation, I kind of wanted to introduce and just kind of more of a disclaimer as to who we are and what kind of skin we have in the game. And then we'll get, hopefully you guys involved, we'll have a dynamic conversation here as a group.
Yeah, so again, welcome everybody. Thank you for being here. As Michael mentioned, and as Sarah mentioned as well, we work for an organization called Dudley and Ryan Atwood. We're a tech-enabled services company, and we work with providers, with payers, with health systems to help them scale their programs around chronic condition management outside of their office. So that works both fee-for-service, kind of vertical, as well as all the way across the value-based care spectrum.
The only reason we tell you that is it helps for you to understand, what kind of data we're going to be providing to you guys and letting you know from where our expertise is. But I did want to poll the room. Who here is in primary care? Raise your hand. Okay. Who here is in an ACO? Okay, so 3 or 4 hands. Which ACO are you guys a part of?
Main Health.
Main Health.
HO, CCPAM.
Okay. Any other ACOs represented?
Center Maine.
Central Bank, great. Awesome. So just as you know, we'll kind of walk through an agenda just so you have an idea of what we'll be discussing, but essentially we'll be talking about why do I need to know about population health? What is population health? We'll dive into a few different health factors that are kind of behind the scenes of what population health is trying to accomplish, and then we'll give you some opportunities and some ideas on how to implement this in practice. But you guys are running a great practice. We're not going to be hopefully giving you too much information there, but more just kind of changing philosophy, think outside the box, and find ways to be able to impact your patients. So before we talk about where we're going, it's always helpful to talk about where we are today. So as you know, with healthcare, it's probably a better term for it is sick care. It's a cost that continues to grow up. When you look at the percentage of GDP, it's about 19% is predicted for next year, and going to break about $5 trillion by 2023. So main point here is sick care is just not sustainable, and there needs to be a change. And I think there's, during the election year, there were some conversations about socialized medicine. We're not going to get into any of that, but because that's throwing away everything that we've done. But there are some trajectories that are already in works, and I think from that perspective, it's help understand where we're going, and you can jump on the train as wherever you need. But the goal is really just to kind of walk you through what that looks like in the future. So Ryan, talk to us a little bit about where we're going.
Yeah, so if you want to just click to the next slide, what we're going to talk about is value-based care, right? So there's some groups here that are already in ACOs. You may have different levels of risk. There's still 70% of physician practices in the country basically say that 75% of the revenue still comes from fee-for-service. So as you look here, we borrowed this from Optum. I think about this a little bit differently sometimes as well, but this is a nice visual. So you kind of move from the bottom left from just fee-for-service, where most organizations still are, and you move up these steps to more and more kind of incentive and then risk sharing, and then all the way to the right. You're basically moving from just transactional, relationship with your patients and your payers, your community, and then as you move across to the right, you're getting more into that managing of population. So as Michael talks about population health and the really expense that we're facing in the country, population health aims to solve that through value-based care. So population health is the framework, and value-based care is a mechanism by which basically payments happen back to your organizations. And so that's how we're all incentivized to manage these populations in an effective way. And so Michael's going to then talk about some of the specifics around population health and some of the health factors and other things that go into population health. For the folks that are in the room from ACOs, you probably work with a lot of this, and others that may have different types of relationships, more along the value-based care spectrum than just fee-for-service. So this may be a lot of news, just old information for you, but I think it's important to level set to think about, here's all the things you need to consider beyond just the clinical care that patients receive. And so, again, just to reiterate, are we moving towards value-based care? Yes, right? So Liz Fowler, the director of CMMI, back in June or July, it was, she said, look, she wants to make it clear that we've never had a stronger commitment to value-based care. And so if you look at just even the recent final rules that came out, whether they're around the expansion of the home health value-based purchasing program, more focused on quality and safety, transparency, these are all things that need to factor into a value-based care system that's focused on population health, however you define that population.
Yeah. So as Ryan showed on that, those steps, you're eventually going to get to a point where you're having to manage a population. So our good friends at Stellar Health mentioned yesterday, if you want to know where healthcare is going, you follow them. They have programs set up, and unfortunately, that's just the way healthcare is. So I kind of like that phrase, and I think that also is kind of wondering why we're bringing in value-based care. It's, that's where reimbursement is, but I think population health is a pretty ambiguous term. So here's just a way to be able to explain a little further. George Washington University did a survey where they asked 37 healthcare executives what population health meant to them, and as you can see kind of from that word collage, all over the board, prevention, care, health, patients, teams, access, treatment, personalized, community, measurement, clinical. So all over the place. However, each one saw it as an opportunity to be able to work together between health systems and organizations to be able to impact the patients in their community that they serve. So just to kind of put some history behind it, the term was coined in 2003 by David Kiddig and Greg Stoddard in the American Journal of Public Health. And they just stated that the health outcomes of a group of individuals, including the distribution of such outcomes within the group, which a lot's happened since 2003. We now have EHRs, we have PQRS, now MIPS and MACRA. So a lot of people complain that this definition focused too much on the outcomes and didn't really explain or acknowledge some of the how clinical physicians are able to impact these. So that's where we'll take from here. Here's just a quote from Dr. Peter Slavin, former president of Mass Gen. Population health is a management approach to redesign the care for a group of people with the aims of making their care better and more efficient. So that's kind of where we'll dive in from here. Go a couple steps further. The University of Wisconsin actually has a population health institute, and they determined that the community of the health is actually determined by a number of health factors, including quality of care, health behaviors, socioeconomic factors, and physical environment. In fact, this ended up being the backbone for the Robert Wood Johnson Foundation model, which is actually the basis for how county health rankings are set up. So from that perspective, we'll kind of dive into each one of these health factors and kind of talk a little bit about how we might be able to impact these. Because if we are held responsible for the management of a population, we have to understand all those social determinants of health and how these patients end up in either a hospital or in our practices. So kind of talking about physical environment, this only accounts for about 10%, but these are things like air pollution, noise, soil, water quality, and then there's also the built environment that humans have created. Things like green spaces, housing, mobility, safety, and sanitation. So kind of going back to, which we'll go multiple times, going back to that slide where Ryan talked about these steps. Those groups that are 3-4 steps ahead, they're trying to say, how am I going to be able to impact these? And so, for a good example would be those groups that are in true capitation. They understand that they might have 100 patients in an apartment complex. They might come in and they might find that there's mold in there. They'll rip up the carpets because they know that a couple $1,000s to be able to do that project is going to help save them money on the back end. So that's really important. Now, for you guys, you're probably saying, well, we can't really do that, but there are opportunities to be able to impact the physical environment. Maybe you guys can partner with a church group or some community services and be able to help build green spaces, plant trees, etc. I know that's kind of outside of our scope, but that's really the goal for this conversation as we're going through this is helping you think outside the box. What can we do to be able to impact our community outside of clinical care, which is our next slide. It's the second largest, it's only 20% though. So I think this is kind of one of the big takeaways is that even if we're all doing our jobs to the best of our ability, we're only impacting that patient's health only 20%. Even though if you think about it on those steps, if you're managing a population, and especially around capitation, you are held 100% responsible, meaning that you are now having to be responsible for the other 80% that we're talking about here, including physical environment, etc. I don't have to go over these, but these are acute hospital care, preventative care, health insurance, oral care, and access to care. These are all things that are very familiar with you, so I'll go through that pretty quickly. Health behaviors, 30% equal to physical environment and also clinical care. These are things that have become a lot more involved in how we document in the EHR, things like smoking cessation, alcohol consumption. They're in our forms, and I think we're starting to be able to get it. But two on here that I want to point out, nutrition and physical activity. We obviously know that this drives the improvement of health, but what can we do to be able to help it? So groups 3-4 steps ahead, they're providing free gym memberships for their patients because they know that if they have access to a community that's exercising, they might be able to increase their physical activity, or providing nutritionists to be able to help provide recipes, etc. So not all of you guys can offer gym memberships, but the goal is to think outside the box. What can we do to be able to improve the community's physical involvement, improve nutrition? Maybe you guys have a cooking class or some kind of way to be able to provide some ways to improve nutrition or education there. And then finally, socioeconomic. So this is probably the most difficult to be able to impact, but it's also the largest segment. So these are things such as education, employment, income, racial segregation. So the biggest one, from a lot of the research and conversations that I've heard, income's being one of the largest. And a lot of people think it has to do with access to care, transportation, and it does that. But there's also a lot of other trickle-down effects from income. A lot of times they're having to choose between, McDonald's along the way, or paying $4 for a pack of lettuce at the grocery store. And unfortunately, that situation just kind of drives based off their income. But what if you're able to provide Meals on Wheels, or maybe you're able to provide, for these groups 3-4 steps ahead, they're providing transportation. They're literally picking up these patients from their house and taking them. You guys can't always offer that, but I think thinking about transportation in a unique way, maybe you guys can find some type of service that is able to help with that. So these are just some ideas, but that's the goal for this presentation today, is hopefully kind of keep things open-minded and think outside the box when it comes to how our patients' health factors impacting their health, and then trying to be able to impact those so that we're no longer providing sick care. Ryan's going to talk to us a little bit about what we can do to provide more value-based care in a more practical way.
Yeah, so we'll go into the next slide in a minute, but as we think about value-based care and what do we need to do to prepare? I mean, obviously by the brief poll we had in the beginning, right, many of you are already in some type of value-based care arrangement, some fall with ACOs. Are there any others here that aren't in ACOs but are maybe somewhere along that spectrum as well, either from a bundled payment for care improvement standpoint, or partnering it with the commercial payers to do some of their quality programs where there's incentive upside only? Yeah, so maybe a couple more folks. So when we think about this, you heard us talk about, the title of the presentation is How to Succeed in Population Health, Identifying and Intervening. So really what we're going to talk about here for the next 15 minutes, 20 minutes or so is just about those steps, right? So identifying and then intervening, because that is where all of this kind of theory and academia around what population health is transforms into how you all operate your daily practice, and then how your community is benefiting from the services you provide. So the most important thing, or the first thing you need to do, is to understand your population, right? Because your population in Central Maine may be different from your population in Southern Maine, or New Hampshire, or Vermont, Connecticut, Rhode Island. So it's just not enough to say, okay, we have this population in New England is our population, right? Because all the resources in the community are different, the geography is different, the physical environment, the socioeconomic, all those things that Michael talked about are what is influencing your population, and they're influencing your population differently than they're influencing the population of others that you have that are even in this room. So I'm sure if we looked at this, right, if I could ask, how many people in here know what their panel breakdown is in terms of the clinical conditions that people have? So, do people all know how many, how many people with hypertension and diabetes and COPD? That's great, right? If you do, but I imagine that a lot of organizations around the country, and many that I've worked with and know, they don't know those things, right? Even if you think you know, once you start to dive in, it's different maybe than what you thought, right? So it's really critical to understand your population. And on the left there, you can see how many of your patients have these conditions. That's fine, right? That's the clinical care aspect. But as Michael showed, through the pie chart there, even the American Hospital Association also agrees that 80% of the health of people is not determined by their clinical care, but all those other factors. So that is very much in line with what we're talking about here. So really that bottom corner, what are the other things? And maybe if you're in an ACO, you're starting to think, or you've thought very long and hard about how your population is affected by those other non-clinical factors. But it's really important for you to do that. So just as a quick note, on the right there is just some data from the CMS Chronic Conditions Data Warehouse from 2019. And that is the CMS population at large, right? So about just shy of 30% of patients have diabetes, a little over about 50% have hyperlipidemia, nearly 60 have hypertension. That's nationally, right? So does that reflect New England? Does that reflect, Connecticut? Does that reflect Maine, Central Maine? northern Maine, right? They're all very different. So when we think about this, it's really important to understand your patient population. And an example of how this works is, so I live in Connecticut. In the state of Connecticut a couple of years ago, they said, we're gonna allocate dollars for diabetes. And they allocated dollars for diabetes care. Yet when I asked the state, I said, well, where are you putting those dollars? They said, well, we're just distributing them. And I said, well, distributing them where? Like, to whom, right? To what populations? And it was apparent to me that they hadn't necessarily, at the onset of, kind of setting aside those dollars, hadn't thought about which populations are in the most significant need of those resources. And that takes me to the next slide.
Actually, if you don't mind,
Yeah, no,
adding
please.
something to this.
Yeah.
Not everyone can see this on the bottom, but how many patients have poor health outcomes? How many patients have socioeconomic issues? And I know I had a good conversation throughout the conference here with a number of different people. Jennifer, I had a conversation with you, and just like, you guys have a population health department, and their goal really is to be able to understand this data. And I think that is a huge step. I think a lot of people can run reports, but do you know those social determinants of health? And I think those are really hard to be able to run reports on. You may not actually ever have your pulse on, but I think that's extremely important just to kind of keep in the back of your mind.
Yeah.
Sorry about that, Ryan.
No, it's good. And even just to piggyback on that, I mean, what's in your EHR is information that's put there by all of us too, right? And so, we talk about, just in the work we do, we talk about problem lists, right? And is the problem list that you have in your EHR, is that really comprehensive? Who do you have on your staff that is going into all those problem lists and making sure that they tie back to the other EHRs from your specialists, from your facilities? Most organizations don't have the resources to do that. So while you need to understand, it often takes another layer to really truly understand, and then take us to the next step, which is stratifying your patients and basically assigning them risk. So many of you are familiar with risk stratification. Maybe you have tools that you use in your practices daily. Maybe your partners or your payers provide you with risk stratification tools or hotspotter reports or different things. But if we look at these are two different versions or flavors of risk stratification from the American Association of Family Physicians or American Academy of Family Physicians. And when we talk about rising risk patients, we're mostly talking about patients that are in that yellow and then lower red band. So these are patients that are, as we'll see in a moment, they're in this next 45%, right? So this is just basic, couple simple ways to stratify based on cost, clinical outcomes, things like that. But if we look at the next slide, and we talk about rising risk management. So again, our belief is that the key to this is to managing your population and succeeding in value-based population health is to understand and then address that rising risk patient population. So you can see that the top 5%, we all know the top 5% are getting a lot of resources, right? That's typically everybody's focus. So whether it's your organization, companies like Landmark, there's often a lot of resources there for people in that top band, or they're in facilities and they're in other places where they have very intensive care going on. That's part of what makes them most expensive. That next 45% though is a much larger pool of patients, and they actually account for nearly 60% of the spending. So those patients are also often most likely disenfranchised from healthcare, right? They have clinical needs, but it's really hard to get an appointment. People are maybe discounting the need that they have, and they're saying, well, you sure it's that? And some of the things we face and we hear from people. So it's really important to address this population, and it's the population that's most likely to move up into that next 5%. So if you're managing in an ACO or along that value-based care, and you're all the way to the right managing a population, or even if you're sort of in the left on that yellow side, where we're talking about programs where there's pay for incentive, and maybe some of those incentives are based on total medical expense, you really need to focus on that next tier, because if you have a baseline and you lose a bunch of your rising risk patients into the high risk, you'll never be able to hit those total medical expense targets that you've set, or your payer, your partner has set for you, and you won't be successful. So as we talk about that, the next slide I'll show you the financial model, which just underscores the reason why that next 45% is the opportunity. And if you're in a total medical cost based program, whether it's incentive only or you have shared risk, that's the area that makes the most sense to focus on. Yes, you still need resources around that top 5%, but if you look in that middle band, that pink bar, even though the per member per month savings is less than that top 5%, it's a much larger group. So if you can effectively manage those patients and prevent them from moving into that top band, and even ideally keep them and maybe move them into the low risk where they can self-manage in a much better way, you're going to save nearly 2 times as much money as if you just focus on that top band. This assumes an 8% savings PVPM, so that's a tough number to hit. But if you focus on that middle band, the return is going to be much more worth your investment. Some of the studies out there, there's a lot, but if you look at the savings opportunity per dollar spent in primary care, it's pretty significant. So the Oregon study says that there's a 13-to-1 savings. So one for every dollar spent in primary care, there's $13 saved somewhere else in the healthcare system. That may be on the high side, or that may be specific to the population within Oregon. But as we can see, it's nearly at least 2-to-1 in terms of what you're spending, and then more likely in the CMS study around chronic care management, it's much greater. It's like $75 to $100 once patients have been worked with for a long period of time.
Yeah, and as we talked about earlier with sick care, what is that? That's where you're only focused in on that left corner, or this left column. If you're providing care for just those patients who are coming to the hospital, that's really the high risk type of reactionary healthcare that's out there versus what we feel like is population health, value-based care, really at its foundation is really highlighting those rising risk patients. So I know our title of our presentation is kind of long, but each word means something, and part of that is really identifying and intervening with your rising risk patients, and this truly is the key to population health. You'll notice as we kind of go through these slides, there's a little thermometer on the right. It's really hard to read, especially for those in the back, but on the left it just talks about identifying, on the right intervening. So we're kind of heating things up. Things are moving from the identify phase and now moving into how do we intervene? How do we take this information and do something with it? Most of you are very familiar with MIPS and MACRA. It's obviously, MIPS itself was created as an on-ramp to help practices start to think about measures, start to compare themselves, and as an end goal of helping them be able to move to advanced alternative payment models. And so, as you probably heard, Medicare is insoluble by, I think they're predicting 2024, and that's why MIPS within MACRA was created as a zero-sum game, meaning that the practices that are receiving the penalty are paying into a program that will go towards those receiving that premium. So just to kind of put some benchmarks, I think it's really important for us to kind of think about step 3. It's a very important step, is just be able to benchmark and compare. How are we comparing with our measures and what we're focusing in on? I know we're really trying to do as well with our blood pressure control, but we're below average. So we need to be able to allocate resources, be able to plan better, be able to even reimburse physicians based on that performance. So here's decile 7 is a typical average on that 10-point scale. Just kind of give you some readings for screening for future fall risk, screening for depression, follow-up plan, colorectal cancer screening, breast cancer screening, depression readmission at 12 months, diabetes, A1C, poor control, and then controlling high blood pressure. You should know these are probably some of the biggest needle movers when it comes to how you'll be able to be in an ACO, or if you were to look at any type of Valuebased contracts. So you notice though, MIPS is just the start. The goal is that you are keeping an eye on some of the ACO quality performance in the national mean, which are in most cases more than that of what you have been held accountable for MIPS and MACRA. All right, I know you can't read probably this slide, but this is kind of the meat of this slide, meaning that here are 2 tangible ways, 2 fee-for-service programs that you should be incorporating that will hopefully help you in value-based care, meaning that there is reimbursement fees. So, and we'll also kind of stop and have a conversation about best practices of who's doing these 2, but kind of talk a little bit about the programs first and foremost. One being annual wellness visit. Who here are actively providing annual wellness visits? Okay, so most of you are very familiar with it. For those who aren't, you can only provide it once every 12 months, but there's no copay for the patient. So they hopefully will see a lot of benefit from that. It is a higher reimbursement, at about $160 on average. But I know from having some conversations this week, there's some ways to be able to even benefit further. And then the second one on here is chronic care management. So Medicare has essentially put together this program for patients with 2 or more chronic illnesses, spending about 20 minutes helping them manage their care per month on a consistent basis. And then the reimbursement is somewhere in the $40 per patient per month range right now. But CMS truly does believe in chronic care management as well as the annual wellness visit. In fact, they just raised the RVUs for chronic care management in the final rule 2 weeks ago. So those RVUs, I think, went from 0.6 to 1, meaning that right now it's about $40 per patient per month, but it will be probably about $60 per patient per month starting in January. So really important for us to be able to talk about these. We'll first discuss annual wellness visit, and then we'll kind of talk about some best practice sharing for those who are providing the service. But two things I just want to point out. I'm not going to tell you how to do an annual wellness visit, but there is some very, very helpful information to when you look at what an annual wellness visit is. It might be the only time that you're able to understand this other 80%, all these other health factors. So these physicians, they're providing a health risk assessment. So understanding the health status, injury risks, behavior risks, urgent health needs, reviewing functional ability and level of safety. So hearing impairment, fall risk, assessing the ability to perform activities of daily living, bathing, dressing, and level of safety at home. These sound familiar? Right? These are these health factors that we're all talking about. Now, I will say, physicians aren't always a big fan of the annual wellness visit. They like to touch the patient. They feel like they want to be able to help in a different way. But this is a very helpful program, and CMS does believe in it. And then that was the identify. On the intervening side, they provide health advice, referrals, and health education to and/or preventative counseling services aimed at reducing the identified risk factors and promoting wellness. So they're taking what you found and they're trying to do something with it. So these are things like health education, preventative counseling that might relate to weight loss, physical activity, smoking cessation, fall prevention, nutrition, and more. Sound familiar again? That's really the point here with the annual wellness visit is that the goal for CMS is that these health factors are starting to be documented, they're starting to be a part of and considered part of the health of this patient. So I wanted to open up the room. I know I heard you got Jennifer's willingness to be able to jump in, but you guys are doing some unique stuff around annual wellness visit. Why don't we kind of sit here and those who are providing annual wellness visit can kind of share some best practice.
So I think the biggest opportunity for us, we talk about access a lot, and I think utilizing our nurse team and embedded care coordinators to do these wellness visits is key. I don't think we tie up a provider for 90 minutes to get these done, 60 minutes to get these done. I think that our nurses and physical providers in the room, they do it better every time. They're going to ask the questions, they're going to be able to provide patient education that I don't think a provider would do. So I think that's a big portion of access for sure.
As a patient, when you have a high deductible and you go in for that, and you know what I'm going to say.
Thank you.
The annual wellness visit, it's bogus. If you call your insurance company and say, what's included in my wellness visit, they can't tell you what labs are included. It's bogus. As soon as you talk about your neck or any other part of your body, it becomes another visit. They charge the patient. The patient is not aware of that. The patient gets pissed off. So you have to define that very clearly. Now, I'm sure everyone's doing things to work around that. The only other thing the doctor can do, or the nurse, is to do the entire visit and not charge that extra visit, and the patient feels like they're, because everyone knows a wellness visit is head to toe. It's not that. That's bull. That's ridiculous. The insurance companies denoted that. That's ridiculous.
How many folks were doing annual wellness visits telephonically? So last year during COVID, 2020 during COVID, I mean, they gave you the great opportunity to do annual wellness visits telephonically. So to your point, I mean, you're not doing labs telephonically, right? You're not doing some of those other things that might immediately change your visit designation from an AWV.
But if I ask about medicine for my neck, it becomes another visit.
Yeah.
And nobody can ever clarify that as a patient walking in the door. That's that socioeconomic thing.
Yep.
If you had told me that, and I brought up some things yesterday in my thing to show the difference, letting patients know, but a lot of people don't even notice it when you let them know.
Yeah.
So they're still surprised.
It's a challenge, and there's definitely probably some further refinement and parameters that need to
And
be
that's where these
set.
best practices come in. How do you do that?
Exactly.
Right.
Yep.
I'll say, providing that patient education, not just from us, but from the care itself. And I think that's unfortunate, but that's the answer folks get from their insurance companies. So then it falls back to the practice, right? So when they're scheduling them, we're having them kind of be educated by the nurse at a no-charge visit first, and education over the phone with less nurses practicing the office. And they have to provide that education of here's what's going to happen during your visit, here's what shouldn't happen during your visit. We'll be making another appointment for that, which would be covered differently. So I think the education calls back to the provider, to the practice itself, but kind of giving that heads up of here's what we're going to do today. If you want to come back, we can absolutely do this tomorrow. So
that makes total sense, right? And so as we're talking
But I
about,
don't think the physician should have to explain that. I think
I
the
agree.
physician should walk in the door knowing.
agree with you, and so and I think that's part of the difference, right? As we talk about moving along that value-based spectrum, right? So in a fee-for-service world, it falls to, it's like kind of left up to anybody. But if you're at risk and you know that annual wellness visit is going to help drive savings downstream, then your risk-bearing entity, whether it's the practice, some partner, or a payer, should be invested in doing those things because they know there's a return at the end, and they will make it much more clear. So I think as we look across that or move up those steps, the people that are all the way to the right, they're doing this at a much higher rate, above 50% than I think what most of the rest of the country is doing, less than 40, less than 30. So
Really good points. Yep.
We actually, when we book the first one, we give the patient a handout on what exactly is included in their annual wellness. And we book that with the nurse. And then we book their chronic care visit immediately after with the primary care.
yeah.
So they come in knowing it's 2 different visits. But we
Yeah.
do the same thing with physical exams. We have to educate patients.
That's right.
Well, and
Your
especially,
knee is not part of your physical,
it's,
But it used to be, so that's what people expect.
and especially patients who have had physicals their whole life and then they go on to Medicare and they say, we've had this too, where it's like the patient goes in, they schedule the physical, well then the practice just changes and say, well, you're on Medicare, we can't do a physical, you need to have an annual wellness visit. Then the patient shows up and they weren't communicated as well, that creates all the problems that.
They save up their problems, where, I'm gonna see my doctor next month, well, all of a sudden, they're calling me 3 months later because they're getting co-paid, and they
Yep.
don't understand why.
So that's a perfect segue into I think Michael's next slide. Everybody's saving things up. So is there a better way to engage with patients in between those visits?
It's almost too good of a setup, but I feel like I should not go there just to sit here and
Hold it on.
No, I mean, you bring up a really good point, and that is it is about setting those expectations. And the thing is that both these 2 programs, annual wellness visit and chronic care management, are fee-for-service programs of what should not be fee-for-service. It should be already included. So these groups that are doing capitation, well, if a patient, they're receiving $700, $800, $900, maybe $1,000 per patient per month, a patient goes to the hospital, they're having to pay for that. So, they want as many of these interactions as possible. And so, again, it's a fee-for-service program, but it's not really. It's really a value-based care program. So really good point there. And then for the great setup there is about chronic care management. I know from talking with a number of you, some of you guys are providing different flavors of chronic care management, but there are some great benefits. Just kind of read some of these, but obviously I think the biggest one that CMS has related to us is that a full functioning great chronic care management program can reduce readmissions by 23%, which is a staggering number. But there's also a lot of other benefits. You can also have improved patient outcomes. When you're thinking about HEDIS, thinking about UDS, MIPS, and macro, etc. You also have improvements. You allow the physicians to be able to work at the top of the license. So, as you mentioned, how many times if your patients are saying, hey, I'm sick here, I've got my elbow hurt here, but I'm gonna see my doctor next month. I'm just gonna wait for this, and then it's all compounded all at once. But I think what chronic care management does is it allows an open conversation with somebody who can treat some of the minor nicks and bruises and allow the physician to be able to focus in on the top of their license. And then also, chronic care management can lead to escalation, where you have a patient where you realize some of their metrics are out of bounds, and you want to be able to, hey, you need to see a doctor, let's go ahead and schedule that now. And so you can essentially escalate things to a physician really being able to work on those most complex issues. Some other benefits is you're able to see improvement patient satisfaction, so your CAP scores get improved, your patient surveys are improved, the patients are also more loyal and sticky. So you've probably seen different competition come into play. Oak Street, Village MD, etc., come into your communities. This might be keeping them just knowing that they have a relationship, they have a patient bond with a care navigator goes a long way. And then you can also reduce those reactionary inbound calls. So practices get less prescription refills, calls into the practice, etc. There are 2 big obstacles, and I want to make sure to mention these. Biggest one being the copay. It is only $6, $8, $10, but there's a lot of patients out there who are having to decide between, do I want this call, or am I going to pay for my prescription, or am I going to get my food tomorrow? And that is a serious thing that you're going to have to work through. But I think if they do see the value, if you are providing value to them on these calls, and they see, hey, I'm getting like a concierge level experience, I think that they're going to be willing to go over that obstacle. And that obstacle is, though, a huge obstacle for sure. And then you also have patients that may not feel like they need help. Obviously, a big one there, too. But there are some benefits. Last, we'll talk about some best practices I've seen, and then we'll open it up to the group and kind of get some of your feedback. But I do feel that this should be if you guys want to provide a chronic care management program in-house, you should have a full-time role, and it might be helpful to have that person off-site. How many times with short staff, if you have somebody on-site, especially part-time, they just get pulled into the practice. The real benefit for chronic care management is to build a patient bond with that patient, one that is consistent, and really half the conversation of it's 20 minutes, right? So the whole conversation isn't just going through the stuff that they have in the EHR. A lot of it is, hey, it's Wednesday. I know you played bridge last night, or how's your cat doing? It's conversations like that, and that will also help open up the patient to talk about those really kind of delicate topics, those health factors that we kind of discussed that they may not be willing to reveal right away.
And just to piggyback on that, because Bonnie, I think what you said earlier about not having, or maybe it was Jen as well, not having the physicians, right, providing those services. We find also in a lot of the conversations we've had that the best chronic care management programs are not provided by nurses, not provided by provider or by physician providers, because typically those individuals want to solve a diagnosis. They want to get to the problem and fix it, right? And so having other staff that is under oversight of your physician, or whether they're MAs or other folks that can engage these patients and talk about things that are not the things they talk about all the time as a patient. When they walk through those doors of that office and they get white coat kind of syndrome there, and they get concerned, they don't open up. The purpose of these is to get them to open up and identify all of those other factors, right? Not that 20% necessarily, some of that 20%, but identify all those other factors that exist in their lives and then help them manage those things. Many of the patients, whether they're starting at a Medicare chronic care management, or in my opinion, best practice much earlier in their life cycle, if you can get your commercial payers to pay for those things or our value-based risk arrangements, it just makes sense to start because they learn, people learn how to manage these things. They have a partner, right, a teammate. So many people are isolated, right, especially in this part of the country, in the Northeast. Yes, if you're in Boston, you might have resources, but in rural parts of Connecticut and in Maine, New Hampshire, Vermont, it's a very different place, and services are not always available. So it's not only a good way to have them remote, but also not have folks that are just so focused on the clinical aspect, because patients get that when they walk in your door, and they need something more than that outside.
Yeah, and we hear these stories all the time. There's so many occasions where someone's blood pressure goes outside of a range, and it seems like they're kind of losing control of their health. And that care navigator asks the right questions, and they find out their spouse had died and their son had died within 6 months. It's like a real story, and then so they just were very lonely, and they didn't have any reason to be able to improve their health. So found a way to step in and actually adopt a dog for them. And all of a sudden, they started improving their scores because they no longer were lonely. They had a sense of purpose. And I think that's really what we're trying to do here when it comes to talking about these health factors, is how do we step in outside of the clinical 20% to be able to impact that 80%. There's other times where we found out that they weren't showing up for their appointments. They were scared of getting on a bus. So we found a way for them to be able to have a friend join them on the bus and show them how to get to their appointment and show up for all their appointments now. It's thinking outside the box in this way. And then kind of just to finish off this slide, you should be tracking your results. I think there are a lot of groups that are reaching out to the patients and they don't have anything in the way of understanding their trends, understanding what's happening and how to be able to move the needle. We do feel like this is very important. And then the program should be meant to keep the patient out of the hospital versus following up with patients after they leave the hospital. That's a different program there, but it's a good program. But I think our goal is really, you're managing the rising risk. When you're reaching out to patients that have just left the hospital, great program, but it's really, those are for those chronically ill. That's for that top 5% that we're talking about. This program should be at scale to be able to really reach those rising risk patients. So this is where I want to stop. I know I've talked a lot, and I want to get you guys engaged. How many are providing a chronic care management program themselves? I already have one volunteer who's willing to talk a little bit, but I want to hear from you guys. What are some best practices for those who are providing this in-house?
I have a question though. First of all, do you have any MAs available that could do that? Because I could use them.
Could.
But,
They're very difficult to hire. I mean, we hire a great number of MAs every month, and it's a challenge, certainly.
My other question is, with the chronic care management, you're talking about timing, you're tracking the timing, and then can you charge if an MA is doing that?
Yes.
You can.
Yep. Yeah. So
Physician does need to review.
yes. Yeah. So basically, so this is like my regulatory compliance. Yeah. So there's a couple key components, right? So if you're going to build the basic 20 minutes of chronic care management services on a monthly basis, it's not 20 minutes even necessarily just speaking to the patient. Some organizations just spend 20 minutes and doing things in a chart. Now I don't think that's nearly as effective as talking to the patient, but there should be patient contact for best practice. You should be identifying all those things. Yes, you can have an MA do that. The physician does need to review the care plan on a monthly basis. The physicians are anticipated to use about 15 minutes worth of their time to do that. That's why the work RVU was about 0.61. It's gone up now. Depending on your model, sharing or having the practice do it, or the physicians, receive all the revenue, it depends on what that looks like, or if you work with a third party to do that, what do you share back with the physicians versus keep practice. I think that depends on the size of practices typically and the organizational kind of ethos. But yes, you can have MAs do it. It is billable. It's going up by about 50% for January 1st. Rural health clinics and FQHCs are going up by a little bit less. They're going up about $12. They use a G code to bill that. But it's really the key to chronic care management is consistency, right? We've worked with practices that used to do they would call 45 patients one month and then 45 different patients the next month. Well, that's not going to be nearly as effective as if you have that full-time person reaching out and talking to people every month consistently, and then escalating things that need to be escalated back to the providers.
Good question. Other questions, comments? I know, Bob, you had mentioned, if you don't mind me calling you Bob McLeod, you mentioned you guys are doing chronic care management as an FQHC. Tell us a little bit about that experience.
Yeah, we are. We started with a company, and that was very helpful because that gave us the opportunity to see how it would work. We brought it in-house I'd say about 6 months ago now, and it's far more effective when you can bring it in-house once you're ready to go. The key is that you should have really a system of integrated care because you're covering the whole patient in their needs. And the other thing is that the 20 minutes can be parceled out, a few minutes throughout the entire month, as long as you get that 20 minutes. And I agree with you that just documenting something into the record is far less effective, because we've found, fortunately, we had a couple of instances where people really needed services at the hospital, and we called ambulances to get them from their house to the hospital. I can't stress enough, integrated care is going to be very important if you're going to do this, and to do it in a way that your clinical staff endorses. And I know that the clinical staff has to document that in the medical record, but that's part of their care plan, and they should be doing it anyways.
Exactly, and I think it's important, whether you do bring it in-house or you use an outside organization, the challenge, right, and I don't know what your organization looks like, but for many organizations, it's really difficult to find staff, whether it's MAs or nurses or whomever. And then if you do move beyond sort of the MA or kind of lower level licensed practitioner level, it starts to get very expensive, right? So if you have nurses or even physicians doing these and providing these services, APR and PAs, it can become very, very expensive, right, to both hire and then maintain those. And so it becomes a challenge to balance the kind of financial outcomes and the profitability of that from a standpoint of bringing it all, keeping it all there and bringing it back to integrated care. But it should be part of the toolkit. Maybe more so than annual wellness visits, although in a value-based care model, we think both really are critical to ensuring that patients are getting the care they need at the right time. And so when we talk about consistent person-centered care delivery, this is what we're talking about, right? And Michael talked about patient satisfaction. CAPs are here, right? So CAPs are a way that you're measured. And so are your patients going to be more satisfied if they only come to you when they have a problem, or when you're proactively reaching out to them and just checking in on them? I know how I would feel. I feel a lot better if people are saying, "Hey, Rod, are you okay?" "Yeah, I'm doing great." "Okay, good. We'll update your care plan. You're hitting your goals. You're doing all those things. We'll update that care plan. And then, if you have any changes in your health, call us, let us know, right, on the inbound side. And then on the other side of that is making sure those integrated care delivery workflows are set up so that when a patient does call in with a critical need, that they don't have to wait a month for an appointment, right? Or they don't have to wait 2 months and things like that.
Yes, absolutely.
We're an FQHC too,
Yeah.
and we've been doing chronic management. The one thing that I found is that our whole staff needs to know those patients that are being chronically managed. Because if that front desk doesn't know, and that patient calls, maybe if you just put the message in versus getting it right to our care manager,
Right.
or saying, oh, okay, this person we know we need to get in,
Yeah.
and get them an appointment. So it's the whole team managing the patients, not just the clinical end. It's the whole team managing those patients.
And that's often the hardest part, right? Especially with staff turnover and finding new people. We were talking yesterday about culture in organizations, as a lot of people have been leaving practices. I mean, it's hard to maintain that culture and that cohesiveness. But yes, I mean, that is the critical piece. If somebody doesn't know, it's very easy for the whole chain to break down, and then the patients are gonna end up in the hospital. And now if you're at risk for that, you know, that just costs you $10,000, $20,000.
And our goal in doing this presentation is to not talk about our business model and how we do it differently, but I do think it is really important what you say, and Bob kind of mentioned it too, is you do have to have physician buy-in and a practice buy-in. You have to have people fully understanding what the right hand is doing from the left, and that is really helpful. You know, we take a different approach, but I won't get into that. The main goal is to kind of give you some of the data that we have found. So here's just kind of a sample size of about 9,000 encounters that we've done this year over 4 different customers, different geographic areas. The only reason I'm showing you this is so to maybe help trigger some ways, how can we replicate some of these outcomes, maybe by not doing a chronic care management program, or maybe help kind of think outside the box. So the largest 2 interventions that we've had has been around education and medication, with appointments being number 3. So we'll kind of talk a little bit about what we found specifically in these interventions. So the top 5 education interventions we've done this year, obviously COVID was at the top of that list. There's been a lot of misinformation about that. So about 37% of our education around interventions have been around COVID, vaccines, and helping the patient just understand what that is. I know it doesn't always fall within that what we typically consider to be clinical care, but it is really helpful. You have a little too much misinformation going, next thing you know, you do have a different health situation in your community. So that was really helpful for us. And we also have diet, hydration, activity, exercise, and then appointments. And so for these, explaining that just if your physician told you to have a low sodium diet, what does that actually mean? Some people come back and take the salt shaker off their table and say, I'm compliant, but they're eating Chinese food every other night and eating frozen food. So it does a lot to be able to provide this education around diet, hydration, obviously a big one, physical activity, and helping them just understand what they can do and think outside the box. And then for you guys, understanding how do we replicate that, right? How can we provide diet education? How do we provide physical activity education, maybe even outside of a chronic care management program? When it comes to medications, this one was kind of staggering to me. Top 5 medication interventions we've had just in 2021. Number 1, compliance. Nearly 65% of our patients that we've created encounters, these are situations where maybe they have a statin and they're having some kind of adverse reaction to it, so you stop taking it. Or maybe they're splitting pills, maybe their prescription ran up and they just can't afford to get more, or they just need some type of intervention when it comes to their medications. That was obviously a massive one. Refill request, confirmed supply, access pickup, and then office coordination. So, we've even seen some groups that as they prescribe a new prescription to a patient, having someone call them and just make sure that they picked it up, or that there wasn't any issues from the pharmacy, or maybe know that there's a payment plan that they could set up, or GoodRx. There's a lot of options to be able to make sure that these patients are compliant. I guarantee this leads to a lot of poor outcomes. It's just patients not taking their medications or not compliant with the exact dosage, leading to adverse reactions there too. And then finally, around appointments. So obviously, setting an appointment with the PCP, obviously being the biggest there at 67%. And then setting up a specialist appointment, 17%. Not a huge number, but I think one that stands out is quality appointments. These are things like mammograms, annual exams, child exam for those pediatricians in the room. So I think these are really, really important, and this is a number that we would expect to go up. Our goal is, what can we do to be able to have this at 20%, 30% in future years, because this kind of really dives back to what we're doing. So maybe finding ways to be able to schedule these proactive appointments so that they're not reactive. Any questions about those interventions?
And just to piggyback, so right now, right, if most organizations are still in fee-for-service only, most of those things are not really your concern, which is problematic, right? But as you move over towards a risk environment, if 65% of the time when you talk to a patient, they are not compliant with their medication, and they're in a rising risk band, they are certainly going to move up into that high cost band. I mean, they are one bad day or one standing up too quick from being in the emergency room, right? And those are the things that if you're catching them early and consistently and building these relationships with patients where they feel comfortable talking about it with your team, then you can intervene at an appropriate time. So next slide, I'm not going to spend a lot of time on this one. We do have just a short time left, about 6 minutes. But this, again, just talking about assessments. Michael talked about fall risk earlier as one of the ways to, one of the assessments or interventions. This is just basically a model that shows if you had 10,000 patients and you did fall risk assessments on about 30% of them because they were maybe at risk, you identified those and you went through those and you said, okay, well, we saved, we avoided 38 falls. Well, CMS, for people who fall, there's about $14,000 to $21,000 after that fall annual spend related to the care for that person. If they have a fall-related hip fracture, it's typically upwards of like $30,000, $35,000, $40,000, depending on where you live. So again, if you're at risk for the total medical expense, well, it makes a lot of sense to do these really basic assessments, and they can be done they don't need to be done by necessarily the physician. They can be part of a workflow that is much less resource intensive and maybe even more effective by doing this. And so the point is that if you're doing that, this slide and the next slide are just talking about how that translates to value-based care and what type of savings you have. So if you can save 38 falls or 10% of those assessments that you did, you can save about $20 PMPM for those patients, and that equates to about $6 per member per month for the entire panel. So that's $6 more that somebody is saving. And if you're not in a value-based care arrangement, then that means it's going back to Medicare, to the payer, or to somebody else, whomever is holding that risk. So as you think about, well, how can I capture, right? I'm saving a lot of value downstream. How do I capture that value? It's by moving along that value-based curve. So on this slide, again, it's pretty busy, but it's just a model that basically shows if you had a baseline with a per member per month cost, somewhere around $650, pretty standard for commercial patients. Medicare's a little bit more. But basically, you're going to have $156,000 of spend annually for that 500 patient panel. If you add CCM to that, and not even just annual wellness, not annual wellness on top of that, but if you add chronic care management, your practice will probably pick up about another $100,000 just based on the reimbursement rates. So that's great in a fee-for-service model. But if you take it one step further, and we expect or anticipate that we're going to save probably at least $50, right? Medicare study in 2017 said that they were saving over $75, close to $100 per member per month for chronic care management services. So if you look at that and you say, okay, $50, then you're going to have a bigger pie as well at the end to share. So that last column is just to show that the difference between what you do with a chronic care management program in a fee-for-service world on 500 patients, really it's 210 patients of actual chronic care management, and a value-based care program, you're adding $20,000 of opportunity back, and that opportunity that belongs to a payer, or if you're sharing a risk, then it's yours, right? So add another 10,000 on top for every 200, 500 patients. I mean, that can be pretty substantial, especially in large numbers.
Good. There's some other programs just to kind of toss out there, but I think we're running low on time. But just taking a look at some of these programs, such as patient-centered medical home, PCMH, principal care management, transitional care management. Some other great programs we've seen from across the industry. Things like Familiar Faces program, where as a patient comes into the hospital, you have a primary care physician there who has kind of an annual wellness visit type of conversation with that patient as they're there. Things like the geriatric emergency department, they're going to be about 500 out there across the nation next year. This is where you have a social worker come in anytime that patient comes into the hospital. Have them involved and understand what led to this situation from a health factor standpoint. And then, for those pediatricians, adverse child experiences, ACEs, good one to keep note of. So, in summary, the cost of sick care is not sustainable. Value-based care shifts the risk from government really to physicians and commercial payers, the responsibility of patient risk. It's important that physician groups, health systems identify and intervene with risk as early as possible, not when it's too late, and then leverage these two programs. What questions do you guys have?
Couple minutes, maybe a question, and again, we'll stick around. You know, if people have questions, or you can feel free certainly to reach out to us offline if that's more appealing.
Yes.
So is success when, I guess being in a hospital system, we have the good fortune of a business development department, and, you know, when we're business planning, we're trying to forecast out demographically, you know, do I know that this area of New Hampshire is going to have a higher incidence of breast cancer over the next 5 to 10 years? Do you guys use some of that forecasting in your tools as well? Or, you know, where can we get to now to make sure that in 5 years, hey, guess what, we decreased the forecasted opportunity, 40% of patients in this area demographically would be, you know, diagnosed with breast cancer.
Yeah, so I think that yes, I mean, we have some very unique technology that we use, but I think one of the, just generally, couple things you can do is start earlier, right? So start earlier in a patient's life, right? If we start by 65, I mean, it's far too late for most of these things. And so, you know, yeah, so with a thing like breast cancer, you want to have people having mammographies as early as is appropriate, you know, according to the guidelines, but to mitigate that downstream risk. The last year and a half has been really difficult to business plan at all, because think about all the people that have moved to your location and away from your location, right? So I'm in southwestern Connecticut, and we had a huge influx of people from New York City. I think everybody in the room, probably no matter where you live here, had a huge influx of people from New York City or Boston. Up to Maine, I mean, I have, you know, family up there, and the amount of people that moved up from Boston and New York and everywhere else is crazy. So it's really important to be able to do that. There are some technology and different things that exist. We have some, you know, proprietary stuff that maybe doesn't quite do that, but is similar in terms of like helping you identify things that aren't maybe captured in your problem list.
Question. Any other questions?
We're at time, so.
I love your out of the box theories, you know, the puppy, everything. I mean, you really have to do that because it makes a big difference.
And the other, I mean, we'd be happy to share some patient stories. We have a portfolio of patient stories from our Navigators, and we have a channel, Slack channel, which is just a messaging app, right? And they share, we have a patient stories channel. And every day, I mean, I go in there for it's incredible what you can do when you have a relationship that you built, right? That you just can't get to as a physician. We have people that, you know, they're like, well, they've had a hole in the floor of their house for years, and they're not able to like move around their maybe wheelchair, and it's like, Care Navigator is like, you have a hole in the floor? Like what? Like what do you, and so gets on the phone, you know, their practice that we're partnered with has resources in the area, so they call the practice and say, hey, we need to fix the hole in the floor, we need to fix X, Y, and Z, and sure enough, all those things, you know, people can't get DME, like, you can't get a cane or a walker, because it's like, well, how are you expecting them to get better? So, yeah.
One step further, if you connect with me on LinkedIn, I share a patient success story once every week, just on LinkedIn, just a video of me talking for 2 minutes. That's these exact stories. Yes?
We built a quarter-mile track on some of our property, and we have cars, and we keep it maintained, even during the winter, really rural Maine. And we have patients that, you know, couldn't even get that quarter of a mile. So, you know, they're all, you know, they're out there now doing at least a mile. You know, it's really, it's made a big difference.
It's tremendous. And I mean, yes, there was probably some investment there, but again, you know, the town will help with that. Like, this is the population, right? This is population health. You're helping your community be healthy. So, thank you all very much for attending, guys. Appreciate it.